I've never in my entire career seen the medical industry say, go home until you turn blue and then come back in and then we'll put you on a ventilator and watch you die. These medicines, but also poisons that we put into people are all counteracting each other. They're all causing polypharmacy issues. The vast majority of my patients are just chronic conditions. We're managing their death essentially. 90% of what we do probably in sepsis was all based on expert opinion and had no actual decent evidence behind it. But we all bought it like that was the gospel.
There we are. Brett, how are you?
I'm doing well, Dr. Baker. How are you?
I'm good. Good to hear. Good to see you. And thanks for doing this, by the way. Let's just start out. You are, obviously you're working with us at Revero, which is totally awesome. So I'm glad to have you in here and talk about that. But let's just talk about your background a little bit. Where you obviously started. You're in Texas. Grew up in Texas. What got you into medicine? How was that experience? And maybe we can discuss, where you're at now.
Yeah, sure. So it's funny. I never really pictured going into anything medical whenever I was growing up. My dad was industrial hygiene and safety and chemical and oil. And that's why we were in Lake Jackson.
Probably Dow Chemical, probably.
Well, he wasn't at Dow. He was at Phillips 66 over in Sweeney. So very close, but we decided to live over there.
Gotcha.
So I kind of thought I was going to go that route. But then whenever I was looking at colleges and everything, one of the main ones that was kind of a throughput for that was Oklahoma State. Wasn't a big fan of Stillwater, so I lived in the Texas Panhandle in a little town called Borger, Texas, for about 3.5 years. So I was pretty familiar with Texas Tech out in Lubbock, and went and toured campus. Really liked it, but I was trying to figure out where to go from there. And my dad had once considered becoming a dentist, actually, and so he actually recommended maybe PA school to me, physician assistant. Looked into it, thought, why not? Looks like a good career. So I actually went up to Texas Tech as a pre-med, pre-PA student, and bit naive on that. I actually, looked at the prerequisites, thought, you could basically get into PA school doing prerequisites, then found out you pretty much need a bachelor's degree. And then there's obviously no guarantee of getting in then. And actually, at one of the health occupation students meetings, one of my old classmates from high school, she asked me if I had ever considered nurse practitioner. No, I had not. Didn't really even know what it was. And so I started looking at it. Decided I'd much rather, if I didn't get into nurse prac school, I'd much rather be stuck at the bedside as a nurse as opposed to possibly not getting into PA school and being stuck in a lab or something along those lines. So actually, I made that decision, and a semester later, I was in nursing school at Tech. So it was very much kind of a thing where I just kind of jumped both feet into it, not really knowing what to expect. I didn't really have anybody medical in my family at all. So that's where all that started. That was in 2005 is whenever I got into nursing school there.
Yeah, gotcha. So I was actually at Tech. I left Tech in actually 2001, so not too far. We're kind of have similar stories. Spent time in Lake Jackson. Spent time up in Texas Tech, up there with the wind and the cotton fields and all that stuff that's out there. But
Yep.
okay, so now you get into nursing school, and then you decided to eventually get your advanced practice degree, so you could practice independently, I assume. But what was your experience like as doing nursing?
So basically in nursing, I always did ICU bedside. In the Texas Tech nursing program, at least at the time, I don't know about now, they were really big on pushing out nurses that were going into ICU, emergency, and OB. And they had an entire critical care course there that was very unique at the time, where we spent basically 8 hours a day, 5 days a week learning intensive care and critical care, and then did the rotations. I really enjoyed it, so that's where I went to. First was in UT Southwestern in Dallas doing neurosurgery, and then After that, I actually moved back down to the Houston area to North Houston in Kingwood, Texas, where I knew some people, and I had actually graduated from high school in Kingwood, Texas. So I went and started doing ICU there, and it was just general medical ICU, general medical surgical, and started ICU night shift there to kind of learn, how things go, get a little bit more, independent without all the doctors around and not without a lot of help. Then moved over to the daytime whenever I was going back to school for my nurse practitioner degree, and basically did everything from taking care of septic patients to chronic illness patients, post surgical. They started a neurosurgery program while I was at bedside ICU there. So, because of my experience there, I started helping out with that program, seeing the post neurosurgical patients, and then did my acute care nurse practitioner on the side, training down mostly at Methodist Hospital in the Texas Medical Center. Still through Texas Tech, but their distance program and then training in the med center.
Yeah, so sounds like much of your care was in acute care, ICU acute care type stuff. And I think that's, to be fair, I think the healthcare system does a pretty good job at that stuff in general. But probably, as you realize now, that many of those acute care patients, particularly those that had chronic diseases underlying, probably wouldn't have been there if their chronic diseases were managed probably appropriately. Is that a fair statement?
Yes, it is. I'm ashamed to say it took me a very long time to figure that out, but that is eventually the conclusion I came to, and that's really where a lot of the disillusionment with Western medicine, critical care, kind of started to develop. Was really starting to see that over time, especially as a nurse practitioner in the ICU, is really where I started to put all the pieces together.
Yeah, I mean, because you see the sickest of the sick in the ICU there. I mean, there are a lot of them are on death's door a lot of times, and sometimes we do some amazing things to keep them alive, and bring them back occasionally. But I mean, most of those people will be return players. Of it, like I said, you never get them healthy. It's just like, okay, we save you from dying, but it's about all we got to offer you, and that type of stuff.
Exactly. It was a
So
revolving door,
yeah, for
essentially.
sure. Yeah, I remember even when I was doing when I was doing trauma as a surgical resident, I remember the head trauma surgeon said, trauma's a disease like everything else. I mean, these same people that come in, they also have this, these frequent flyers are always getting in traumas because either they're drunk or they're on drugs or they just don't
Yep.
take care of their lifestyle. And it just becomes a repetitive event for many of them. So, okay, so healthcare is clearly broken in many ways. We all know that. I think even most physicians in that would agree to that, but most of them are just like resigned to that. Hey, I got bills to pay. I sacrificed, I spent 10, 15 years getting education. Now I need to pay my loans back, provide for my family. It is what it is. And we're just going to plug on. Let me ask you before we get into the Revero stuff, because I suspect that the experience is a bit different at Revero than it is in certainly in neuro ICU or whatever, medical ICU. What were some of the things that when did you wake up to this, and what was it? Were there some frustrations associated with what you're doing? Did you find that the system just doesn't facilitate maybe doing the right thing?
Yeah, there was definitely a lot of that. I would say, it's funny. One of the other Revero clinicians you recently interviewed was Sky Thomas. She and I actually crossed paths working at the tele ICU.
Because she's in Houston. Is she in Houston as well? I think I can't remember.
She is.
Yeah, that's right.
And we were both working nights. She was a nurse at the time. I was working there as an NP, and I saw that she was losing a lot of weight and looking a lot healthier. And she told me she was doing the ketogenic diet. And I had definitely heard about it before, but really thought it was more of a fad thing. And instead of doing my due diligence, I just kind of wrote it off. Was pretty prejudicial, to be honest about it. But whenever I saw that she wasn't having rebound weight gain like I had always experienced trying to do the standard stuff, I said, well, there's got to be something to this because she's not, regaining weight. And I said, so, maybe instead of being so prejudicial toward it, maybe I need to actually do my job and actually look into the science behind it. Maybe there's an actual reason why this is going on. So I started doing that. And in between patients, whenever we were doing the tele ICU stuff at night, I started going on YouTube, found Dr. Ken Berry, and like I said, started looking at the science behind how ketogenesis works and, why it's a better option. So then I started doing it, saw the success as well. And that's really whenever things really started to kind of kick off. Not only my perception change on health and prevention in the first place, but then COVID hit. And then I saw basically an entire medical industry that was so close minded to anything that could possibly help COVID patients um, before they decided to turn blue and end up in the emergency room. And I thought, well, this is absolute insanity. You guys are doing something and spouting these things that you weren't taught, that basically, really you should have been more open minded to early therapy. I've never in my entire career seen the medical industry say, go home until you turn blue and then come back in and then we'll put you on a ventilator and watch you die. It was absolute insanity, and it really made me angry. Um, it's always been, especially doing ICU, treat early, make sure that you've got all the stuff going, especially like, for instance, sepsis patients. Get the antibiotics in. You got an hour. You've got all these other things to do as quickly as possible. And then we totally flipped it during COVID and said, no, we're not actually going to treat people until they're basically hypoxic. Well, that made no sense to me. So then I really started questioning the entire medical industry. I said, if these people are so willing to buy these problems and just go along with it and not speak up, well, there's probably some other things I've missed in the past where that may have been the case as well. There was an instance before that as well. I was actually running an ICU at night in the North Houston area, and the sepsis committee chairman for the hospital had stepped down. So they needed somebody else to step in, and because I was actually the person who started the nocturnal nurse practitioner ICU coverage program there, they asked me to step in and do that. So I did, and that's whenever I really started getting into protocols, things like that, learning that side of medicine, and started going into core treatment for sepsis, what the government wanted, what standards we had to meet, where those standards actually came from, and where those recommendations came from. And then I came to find basically 90% of what we do probably in sepsis was all based on expert opinion and had no actual decent evidence behind it. And but we all bought it like that was the gospel. And it was just, that's the way it was. But if you actually looked at where those recommendations came from, they really had no basis in much of anything. And that was probably where I really first started questioning what we were doing, because I saw that really probably only about 5 or 10% of an entire sepsis protocol was actually helpful for a patient, and the rest was just filler. So that was pretty disappointing, but pretty eye-opening as well.
Yeah, and it's kind of, when you're buried in it, you're inundated and surrounded by it all day long. It's hard to see outside of it in many ways, and it's kind of like, because and often because you're as you probably know, I mean, you're busy, you're working like crazy, you're trying to catch up, trying to do all the administrative and paperwork stuff that comes with anything. I mean, it's constantly charting. I'm sure as a nurse, I mean, charting was probably 50% of your life or something like that. Some
or
ridiculous
more,
amount.
unfortunately.
Yeah, or more. Yeah, unfortunately. So you can't really even take a moment to think. All right. So obviously, let's talk a little bit about Revero now. So obviously, we have a different model. We're talking about let's actually heal people. Let's do that. How has that been going for you? And what anything you want to share about that? Hey, folks, it's Dr. ShawnBaker here. Hey, if you or someone you love is suffering from chronic disease and you're tired of just managing symptoms with potions, pills, and procedures, I want you to check out Revero.com. Our team of dedicated professionals is committed to tackling the root cause of your issue and finally getting you healthy. Hurry up, though. Our spaces are filling up very quickly.
Yeah, so I basically jumped in with both feet. One of the other clinicians had to leave their position, and I guess I was one of the first providers that was coming on as you all were expanding that had licensure in Texas. And I actually have licenses in about 40 states. So basically, they had me take over a patient census right from the very start. So I was learning all the protocols for deprescribing essentially, and Revero's methods and those kinds of things. So I think I took over about 30 or 40 patients right from day one, where I was having to go through their charts and try and figure out what all had been done with them, where they were at, and everything. So, like I said, I was just kind of seeing patients right from the very beginning, and just kind of jumping into the chat aspect of things where, the health coaches and the patients were talking back and forth, learning what the health coaches did. And I've been onboarding patients now as well for about 6 months. I joined you guys in December of 2024. It's been going very well. Seen a lot of patients come off of medications. Had patients graduate out of the program, which, normally when you lose patients other ways, especially in the ICU, it's usually not in a very good way. But in this way, it's actually more of a happy occasion because they've got a lifestyle down where they've gotten healthy and they can go do it on their own and hopefully not need us as clinicians in the future, except for, minor illnesses and things like that.
Yeah, I mean, it's again, ICU is a little different because you'll put people on drips and you'll take them off drips. But I mean, the chronic medications, they usually generally just stay on for the rest of their life. That's how these drugs are designed and manufactured with that express and purpose. Is you're going to be on this drug the rest of your life. And maybe for the first time in your career, is that a fair statement? For the first time in your career, you're regularly deprescribing chronic medications?
Yes, yeah, because like I said, I didn't do much in the way of primary care. The primary care experience I had was shortly after nurse practitioner school. I didn't feel comfortable going as a provider in the ICU because it's a whole different perspective as opposed to the bedside nurse. Bedside nurse sees symptoms, treats things without necessarily always looking at causes, whereas you have to totally flip that perspective whenever you go in as a provider. Didn't feel comfortable with that, so I actually did house calls for almost 2 years for Medicare, Medicaid, and disabled patients. And even then, some of them were on 20, 30 medications at a time. It was unbelievable. So I learned my medications very well. But in terms of deprescribing them, I didn't have any basis to go on. That's just not something you're regularly taught in, nurse practitioner school, nursing school, any of those. So coming on here, yeah, it's been a whole different ballgame because you guys actually have, step by step kind of instructions and things. Obviously, that doesn't override necessary clinician discretion, but ways in which to actually approach deprescribing in a safe manner and an actual medically managed way so that it is a safe process for the patient. So yeah, that has definitely been a change for me.
Yeah, and I guess, when you're in the ICU and you're seeing a lot of sick patients, I mean, I guess you get some level of satisfaction in getting someone out of the ICU, but it seems like, and I can tell you at myself as I spent many, many years, decades doing orthopedics and, replacing people's knees and fixing their broken hips and their broken wrists and, fixing their ACLs and rotator cuffs and all that stuff. And that was, I mean, I did enjoy aspects of it, but it pales in comparison to what I see now. I mean, it's like complete life-changing stuff, which is really, really fun. I don't know. Do you get how much? I mean, because I correct me if I'm wrong, but are you still doing a little bit of the other stuff as well? Are you still doing some of the acute care stuff and doing a little both?
Yeah, I'm still doing some part-time stuff, doing the tele ICU and everything. Um, and that was a bit of a change. I mean, it's like 90% of what I used to do at the bedside as an NP. Obviously, I'm not doing the intubations, running codes, central lines, all that kind of stuff that I used to do. But I am still involved in that, and honestly, there's just not much satisfaction in it anymore. I'm good at it, and that's why I stay there. And I like to keep my skills up from the standpoint of working on critical patients, a differential diagnosis, making sure I'm still up to date on those kinds of things. But there it comes with the realization that. Much of what we do is actually just managing these patients who've had chronic conditions that have just gotten to the point where they need ICU. And even if I get them out of the ICU, I will probably see them in 2 or 3 weeks. And so there's not much satisfaction in that. Patients who are coming in for acute issues, like maybe they've had a heart attack or maybe they've got an acute infection and we get those cleared up and then they go back to their daily life. That's great. But that's not the majority of our patients anymore. And I've noticed this. I've been an NP since 2011. In 14 years, I have seen a massive change, even over that period of time, in what we're actually seeing. That the vast majority of my patients are just chronic conditions. We're managing their death essentially, and they keep on bouncing in and out, in and out. And honestly, I probably know them better than their primary care docs do because at some point I actually see them more than their regular doctors do because they're basically going straight from the hospital to their long-term acute care or their nursing home, then coming back to the hospital, and they're probably not seen by their primary care anymore. So yeah, it's a much more fulfilling kind of situation here because we're actually getting people healthy, hopefully avoiding ending up in my ICU bed. So that's really what's driven the massive career change here.
Yeah, and as you know, I mean, acute care, like ICU care, is exorbitantly expensive. I mean, like a night in the ICU is thousands, if not tens of thousands of dollars, depending on what's
Hmm.
going on. And sometimes you'll have people in there for weeks and weeks on end, uh, and many of that could have been avoided with appropriate primary care at the beginning. And so I cannot imagine. I mean, we run nearly $5 trillion a year in medical care costs. It's a huge percentage of our GDP. Um, and it's very profitable too. That's the unfortunate side, is it's quite profitable to
Hmm.
run up these huge bills. Where do you see medicine going? I mean, as someone who's on both sides of the fence right now, you're doing what I think is the right way to do medicine. You're also doing some of the acute care stuff. I've got my thoughts, but do you have any idea like what things are changing? I know there's a lot of corporations that have bought up. I mean, very, very, very many small practices have been bought up by corporations. Most
Right.
hospitals have been bought up by corporations. Where do you think things are
Hmm.
going?
Mm. That is actually a tough question because of putting in the perspective that you just did. Um, we have a lot of number crunchers at the top, running a lot of these massive hospital corporations, like what you're referring to. Um, and I think that unfortunately, we are still very much on a sick care basis. The vast majority, I think, of the medical industry is like you mentioned, well intentioned in terms of a lot of the providers, but also totally swamped with the massive workload that's actually only getting higher because of the chronic conditions. That we aren't really looking at what we can do to prevent it because we're so involved in our daily um, aspect of things in terms of the inpatient um, care that I don't see that part getting better. And until we have a perception change in terms of prevention and what we're putting into our bodies in the first place, I really don't see that the inpatient side, the acute care side, is going to get any better. In fact, that's part of the reason why I left because it ran me into the ground. My health was suffering, my mental capacity was suffering. Um, but on the bright side, there are a lot of clinicians now who are finally kind of getting that perspective and starting to do more research into things like what we are addressing with Revero, realizing that these necessarily medicines, but also poisons that we put into people are all counteracting each other. They're all causing polypharmacy issues. And maybe we need to actually start fixing people and fixing problems before they start getting on these medications. And so there's that aspect that's good. And I hope that with places like Revero, gathering a bunch of data on patients who are going ketogenic, carnivore diet, and that kind of thing, that we can finally push that kind of information out to the public, but also to the insurers, and actually have these things actually covered so people, won't be so resistant to it, because, it's tough out there for a lot of people when you're paying for this kind of thing out of pocket. They want to go with only what insurance will cover, or at least partially cover. And a lot of that comes down to, what they can afford. And hopefully we can make that more affordable if we can get the data out there and have more buy-in from these insurers and other organizations. But in terms of the corporations buying up a lot of things, I'm very much a conservative guy, so I'm not an anti-corporation guy. But whenever it comes to what they are looking at, there needs to be a balance between profits on that side and actually what's doing right for the patient. And I think the ones who aren't who don't have a clinician background, which unfortunately is a lot of who's running these places anymore, they're not they don't have the background that is necessary in order to get that proper balance. And so I think we've gone much too far in the way of the financial aspect, and kind of don't have people with the right background running it. Some of that goes back to, the federal laws and kickbacks and things like that have actually barred clinicians from running places because they're afraid of all the financial incentives. Some of that's justified. I think some of it's not. And I think that has actually come to hurt our industry overall, especially in the last probably 10 or 15 years.
Yeah, for sure. Let me ask you, it's interesting because obviously someone goes and ends up in the medical ICU or the neuro ICU. They don't really want to be there. There's no one's like, oh, I want to go to the ICU. I mean, it's like they have to be there for reasons. And I don't know how much interaction you have, because when someone's obviously they're intubated, you can't really communicate with them. They're completely out. But I mean, if somebody's, maybe they're awake and kind of transitioning in or out, you can have some discussion, but again, they don't want to be there. But the Revero patients, generally want to be there. They want to get healthy. I mean, it's got to be a different sort of dynamic. Is that correct?
Absolutely. Yeah. Because, whenever, whether you're at the bedside in the ICU as the nurse, or whether you're the provider in the ICU, basically you're pushing out a lot of orders and taking away a lot of the autonomy from your patients, for better or worse, and a lot of the time, because it's necessary given the situation. But here we are granting the patients more autonomy, trying to help guide them more in terms of how they're addressing their lifestyle and diet, and trying to make them more accountable to themselves. And just the program obviously helps with consistency and maintenance in terms of those things with the coaches and the constant contact and things. So yeah, it's a much different situation. Like I said, I'm basically in charge in the ICU. Don't really ask the patient their opinion on much, other than, if they have something where it's actually their choice on how we proceed in the plan of care. Obviously, we're going to have that discussion. But really, with Revero, I would say that the patient, the client, is really mostly in charge, and we're just there to guide them on that journey, which is taking a step back, and it's a good step back. Is like I said, if we can get them to be more accountable to themselves and get them off these medications and things, and they go on their own way because they've gotten healthier, that's really the goal here, which is a much better way of doing medicine.
Yeah, you mentioned, obviously we've got sort of a dynamic where the clinician sort of runs the show, kind of manages the medications, comes up with the plan, and then you have the execution, which largely is assisted by either the technology itself or the coaching input. I can tell you, when I was practicing orthopedics and I started to realize that, hey, there's a better way, maybe some lifestyle, I had no resources. I mean, literally, there was nothing I could do for the patient other than say, hey, go read this book or watch this video. There wasn't really a team dedicated to doing that. How do you find that to be useful? How useful has it been to have a supportive team and all the other sort of things that encourage those behavior changes that are necessary?
Yeah, it's been very helpful because before this, I was basically kind of doing a lot of the same thing once I figured out a lot of the problems in any nutritional basis that I had been taught, which was pretty well garbage, to be honest. Um, what I was having to refer patients to was, going online, going onto YouTube, going onto these other platforms, looking up ketogenic diets, looking up carnivore diets, and that kind of thing, and just telling them, "Hey, here's this guy, Dr. Baker. Here's a a link to his information, Dr. Kim Berry, and these people, and go watch some videos, see what you think." And I did get a lot of buy-in from patients that way, but there again, it was still very much a go do your own research on this and see what you think, and if you want to implement it, great. I can't be there to help you. So it's not backed by the medical industry. It's not backed by any insurance I do, and if any insurance I have for malpractice, and unfortunately, I can't be on call for you 24/7 to help you out in this kind of thing. You're going to have to do it on your own and be very careful. And just know that whenever you bring it up to your doctor, they're probably not going to like it. But now I actually have the access to the Revero system, and one of the biggest helps for me is having the health coaches behind me because they are very well versed in a lot of the lifestyle stuff that I have not been versed in. So I tend to let them run that aspect of things and try not to step on their toes too much because they know better what they're doing from that aspect than I do.
So the patients you've been seeing, you said you were in panel with a bunch from the beginning, and then obviously more over time. What's a typical patient tend to look like, disease wise, sort of demographic like?
Mostly high blood pressure, diabetes, prediabetes, obesity, just general metabolic dysfunction. Have a lot of patients who are having skin eruptions of different conditions, and then a smaller subset, but seems to be growing a bit more recently, is the autoimmune aspect of things, which does play into a lot of the skin parts, but more joint pain, that kind of thing, arthritic, psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, all those conditions. Whenever we're talking about autoimmune conditions where they've got a lot of just chronic pain, got a lot of the gut issues, the IBS, Crohn's, ulcerative colitis, those patients as well. And then a couple sprinklings of some Lyme disease patients where they've got the chronic issues from either just the ongoing aspects of Lyme or misdiagnosed Lyme that was never really treated appropriately in the first place, and now they've got the chronic issues from that as well. That's been the majority of the patients I've seen so far.
Yeah, and how I mean, obviously hypertension is a very common issue. Obviously, so is obesity, diabetes. Those are all real common. How long does it typically take for you to start seeing positive changes in the patients to the point where you start talking about deprescribing? What's a typical time course
Not
look
long at
like?
all. Whenever it comes to the hypertension aspect, the high blood pressure aspect, I'm usually cutting down the dosage, if not taking off antihypertensives within about 2 weeks.
Yeah, that's pretty amazing. Yeah, that's and it's surprising, and we'll go back to the COVID thing because I saw a lot of frustration with this as well. I mean, we had, this sort of, this is the way we're going to do COVID, and yet, and there's no sort of medical condition, chronic medical condition that doesn't get worse with poor lifestyle. I mean, that's well
Mhm.
known. And as you mentioned, 2 weeks, you got people coming off hypertensive meds, off diabetes meds. That could have very well been done during COVID rather than just shut everybody down, stick them in masks, stick needles in their
Absolutely.
arms. And we literally spent zero. I think there was zero federal discussion at all about any of this stuff, or at least anything that came to, public, uh, information being put out there. So it is amazing how quickly things can change, and that's really, I think, a real important point. Um,
One thing about that, actually, the COVID aspect of things, whenever it came to the chronic diseases, um, this is something that really frustrated me. The biggest part, um, again, that they didn't put any federal money towards the preventive aspect of things. The vast majority of ICU patients were either extremely elderly, uncontrolled diabetics, or severely obese. We did not have a lot of young, healthy people coming in with COVID who were going on ventilators and dying. That was absolute nonsense that unfortunately that was perpetuated out there, and there wasn't much of a medical voice talking about how, no, these are not the people we're seeing. We are seeing elderly who were likely to die from something else anyway. Let's be honest, they were in their 80s, so that's just the reality of the situation. And then we saw a lot of people who were diabetics who didn't take care of themselves, people who were extremely obese, had BMIs 40 plus, or a lot of alcoholics. And there were the few that had congenital abnormalities that were also obviously deeply affected by these types of infections, but that's the case all the time with an infection in patients with congenital issues. But that was my biggest frustration, was that we didn't address the things that were actually putting people in the ICU that were already likely to die from something else or be severely injured by an infection, whether it was COVID or anything else.
yeah, yeah, this definitely was. I think most people would agree that was a sort of a black stain on medicine, which is already full of its own problems. That didn't help anything. But I think on the good side, it probably caused a lot of people to rethink things, like yourself included. I was already there before this happened, but I think it's caused a lot of physicians to say, "Hey, wait a minute, there's a real problem with the way we the business as usual things not working well." Um, well, I'll tell you what, this has been wonderful. Anything else you want to share before we go step away?
Uh, no, no, I mean, not really. Everything, with Rivero has been going very well. Um, I've actually really enjoyed being able to see these patients. I think it's a very good program for people. Um, there is one thing. Now, when we're doing these changes, lifestyle changes with Rivero, one of the things that I always try to keep in mind and have my patients know is, some things do actually still require Western medicine. Let's not throw everything out. Western medicine is not all bad, right? There are some things that do require some kind of pharmaceutical intervention. There are some things that do require some kind of surgical intervention. Um, but even still, even in my patients who were not able to get 100% recovery in their conditions, we are still able to get you guys much more metabolically healthy and put you in a position that these conditions are much easier to manage, or your recovery from whatever intervention we're having to do is going to be so much better. So I would say come into it with high expectations, but realistic expectations. We're going to do everything we can to get you metabolically healthy. Is it going to fix every single aspect? No, it is not. But everything that you're dealing with is going to be so much easier to deal with if we get good buy in from our patients, our clients. They're consistent with it, and they work with us. We will do our absolute best, and as little amount of interaction as you have with Western medicine and surgery and medications and everything, uh, that's the goal here. Everything's not entirely fixable, but your life will improve significantly if we can get you in a much better metabolic state. I did it myself. I was pre-diabetic and over 200 pounds at 5'6" after coming out of graduate school. I was in a terrible spot. Went ketogenic and carnivore, and so much better. Fixed the prediabetes. I was on my way to very, very early problems, and I've got young kids. I needed to fix that. I just turned 40, and I'm in better health now than I was then.
Good
So
for you.
it's a great program. Highly encourage you guys to join on to it.
All right. Well, thanks, Brett, for doing that. Appreciate it. I'll let you get back to your day. Stay cool. I know it's humid in Texas, particularly in Houston that time of year. So I don't visit my mom, my sister in the summertime, just because I'm like, I'm going to stay. I'm in Washington State, and it's actually,
I was going to say, you off to the Pacific Northwest.
Yeah, it's nice right now. And this is a beautiful time to be up here. Yeah, exactly. All right. Thanks so much, Brett, for doing this. Appreciate it.
No problem, Dr. Baker. You have a good day.